Good afternoon, everyone. Welcome to our first Yale Sleep Medicine Grand Rounds for this fall of 2025, and thank you for joining. My name is Ritika Thapa. I'm one of the pulmonary critical care and sleep medicine faculties here at Yale. Before I introduce our today's speaker, just a few housekeeping announcements. Please take a moment to ensure that you're muted. In order to receive the CME credit for attendance, please see the chat room instructions. You will be getting instructions soon. And you need to sign up to get this credit. And if you have not signed up already, please send a message to Debbie. And if you think anyone else is interested, please reach out to her as well. If you have any questions or comments during the presentation, please use the chat room or take the opportunity to unmute yourself at the end and ask questions, and I will moderate the session. Recorded version of these lectures will be available on YouTube a few weeks after the presentation. And today I have the pleasure and honor of introducing our own Dr. Brian Wojeck. He received his medical degree from the University of Arizona and his Master of Public Health from Emory University. He completed his internal medicine residency at the Mayo Clinic in Phoenix and both his fellowships in sleep medicine and endocrine at Yale. He has additional training in obesity medicine and is a weight management specialist as well. He's currently an assistant professor of medicine in the section of endocrine at Yale School of Medicine. His clinical and research focus is the comprehensive management of the interrelated disease processes of diabetes, obesity, and sleep disorder, exploring how sleep disorders contribute to metabolic dysfunction and the effectiveness of the novel therapies, and has recently published on topics such as the impact of SGLT2 inhibitors on sleep apnea. He has lectured nationally and internationally at various meetings, especially on obesity management, sleep disorders, and diabetes dysfunction. He's received many awards and is the recipient of several grants, including on NIH T32 Fellowship, and has authored over 30 publications. Having worked with Dr. Wojeck for the last 3 years, I can say he's not only deeply committed to his patients, but also refreshingly humble with his witty humor that makes him a colleague everyone enjoys working with. Thank you so much for being with us, Brian. And without any further delay, I would like to hand it over to you to share your expertise on obesity and sleep-disordered breathing, a focus on novel treatment strategies.
Thanks, Shri. I really appreciate it. In addition, I have brought back up my colleague, Dr. Noakes from UCSD. We do some research together. So he's going to help me out with some of the respiratory phys at the end if there's some questions about that. I'm not a pulmonologist. I'm an endocrinologist and a sleep doc. So I think it'll expand our conversation at the end. All right. So without further ado, let's get into it. My disclosures are as follows. I've served on advisory boards for Corcept Pharmaceuticals and Amgen. I've done consulting work for D.E. Shaw, KeyQuest Health, Leerink Partners, Slingshot Insight, and Tegas. By the end of this lecture, I hope you will understand the prevalence of obesity and obesity physiology, understand the physiological effects of obesity on sleep-disordered breathing, and be able to determine appropriate medical options and really also surgical options for patients with obesity and sleep-disordered breathing. So let's get right into it. It's not an obesity talk without a heat map. All right, so obesity is prevalent. It's been growing year by year in the US and really worldwide. It's high, there's a higher prevalence among racial minorities, including African Americans, Hispanics, Native Americans, and prevalence in the U.S. is approaching 46% now, according to the CDC. So we use BMI as a measure of obesity, and in truth, it's an imperfect measure, right? So things that we have to think about are body composition. So these two gentlemen might have the same weight and might have the same BMI. But in fact, it might have a different visceral adiposity. So things that we should we should think about. Elderly adults may have more sarcopenia. Cardiovascular and metabolic risk vary by ethnicity. So individuals of South and East Asian ethnicity have more cardiovascular risk at lower BMIs. And obesity really might start at a BMI of 27. High muscle mass will certainly affect the BMI and may not be truly reflective of, someone that's a higher BMI might not really have the same cardiometabolic risk. What's a better, cheap, and easy measure of of risk would be waist circumference, right? So you have that kind of caveat there. All right, obesity is undertreated, although this is changing. This is changing worldwide. So this is an old study. It's a retrospective analysis, 2012 to 2015, looking at IMS Health National Prescription. It was an IMS Health National Prescription Audit, looking at anti-obesity pharmacotherapies versus diabetes drugs. The big picture was that 86% of patients with diabetes were treated with appropriate medicines, and less than 0.5% of eligible patients were treated for obesity. This is obviously changing. Where there's been a big shift in how we think of obesity, and we're starting to recognize it as the disease that it is. So let's talk about it, and let's talk about the physiology of obesity. All right. So when we think about fat mass, all right, fat mass is regulated during development, right? We think about baby fat, quote unquote, kind of quote unquote baby fat. And sometime at some point, as people age, they lose the baby fat. But there are significant body composition changes in puberty, and there's sarcopenia and increased fat mass with aging. And there's obviously body composition changes with menopause and pregnancy. So fat mass is regulated in lots of ways throughout the lifespan. Satiety is regulated via hormone signals, right? So this is what we target, and this busy slide is not, I don't mean for this audience to memorize it, but I will highlight these two pathways, which is the POMC-CART pathway, which is one of the primary mechanisms of GLP-1. And then the NPY-AGRP pathway is our primary hunger pathway. So when we think of POMC-CART, it's more of a satiety pathway, not more of it is a satiety pathway. You see here a lot of the other targets that are being investigated. In fact, many of these have, there's new data on drugs that target these different receptors. So this is ongoing. But the bottom line is we are targeting satiety with these medicines. These medicines do not increase metabolic rate. When we think about weight, all right, and classically we've always said we should diet and exercise. And it's not to say that diet and exercise aren't an important part of weight management. They are. Okay, healthful diet and regular exercise are key components to helping people lose weight. When we look at studies and look at meta-analysis, they don't cause a lot of sustainable weight loss. Diet and exercise alone cause about 2.4 kilos in sustainable weight loss. It's not to say that patients can't lose weight. They will regain it, and that's because of the defended fat mass. 2 to 4 kilos is not nothing, right? It's an important amount of weight. It's just to say that many of our patients, at least the patients that I see, need more weight loss than that. When we think about very low calorie diets, that's also true, right? So a very low calorie diet is defined as a diet of 800 kilocalories or less. All right. And even in those populations, we see that there's weight regain quite rapidly. It's again not everything necessarily, but those patients will usually regain weight within 2 years. All right. So more discussion of why this is, a physiological, really interesting study. This was 32 premenopausal women, aged 18 to 50, BMIs 22 to 27, that underwent liposuction versus no treatment. The patients that underwent liposuction returned to baseline within 6 to 12 months, right? Because again, the fat mass was defended. These patients had a defended fat mass. Liposuction is an ineffective way to treat the primary disease of obesity. Okay. Here's one of the studies that kind of really got me interested in obesity and obesity management. You may or may not remember there's this reality show called The Biggest Loser. So The Biggest Loser, the concept behind it was that not patients, the participants um, were heavy to begin with, probably all class 3 obesity. And whoever lost the most weight by the end of the show won money. All right. So as you can see, the patients started at a BMI that was quite high, class 3. By the end of the show, they after 30 weeks of competition lost to class 1 obesity, maybe on average. The interesting part is that before competition, resting metabolic rate was normal for age, sex, weight. 6 years after competition, it actually was low. And I'll have you look at the physical activity line at the very bottom. Physical activity remained quite high in these patients, but they still regained much of their weight. There was a metabolic adaptation, right? About 500 kilocalories per day. 500 kilocalories per day is a lot, right? So extreme weight loss with these kinds of fad diets and may actually be harmful and cause counterregulation. It's not to say that patients shouldn't exercise and diet, but the goal is not to kind of have patients starve themselves, so to speak, right? That doesn't work, not long term. So what's the new paradigm? How do we think about this, right? So there's a certain defended fat mass, and that defended fat mass is the balance between energy expenditure and energy intake, right? Why does this shift? Well, we live in an obesogenic environment, right? And so the paradigm, how we should be thinking about this is our first job is prevention, right? So primary prevention, we want to prevent obesity. And how do we do that? We want to have good sleep. We want exercise. We want healthful diet, all right? Avoiding processed foods, all right? Avoiding stress. Secondary prevention is once patients have already developed obesity, we want to prevent the complications of obesity. So things like fatty liver disease, diabetes, sleep apnea. And then we think about tertiary prevention, where we treat the complications of obesity. So once patients have developed these complications, we want to treat them in addition, right? So that's how we should be thinking about obesity as a disease process. So how do we do this? Well, how do we adjust the defended fat? All right. Well, we want to think about life. First, we want to talk about the quote unquote lifestyle changes, and we think about calorie dense diets, sleep deprivation, circadian disruption, high stress, and actually activity, right? So these are the big things that we can do. If people eat more healthfully, sleep better, reduce stress, and obviously remain active, this will help the defended fat mass. So let's get to the details of what that might mean. This is a study of 811 overweight patients that were randomized to different macronutrient diets. All right, looking at different amounts of fat, carbohydrates, and protein. And the truth is that it didn't really matter which diet that they were randomized to, just how long they were on that diet. The caveat to this is that there are certain diets that have real data behind them. All right, and that's for instance, Mediterranean diet has important effects on cardiovascular health, as does the vegetarian diet. Low carbohydrate diet is often preferred for patients with diabetes. But the big picture is that adherence is more important than a specific diet. This was another study looking at different kinds of diets. Looking at we may not remember this, but there was like the zone diet Atkins, Weight Watchers, and an Ornish diet. And the important piece here was that it didn't matter which diet these patients were assigned to. Rather, what mattered was adherence, right? So if a patient can't adhere to a certain way of eating, then they need to choose a different way. It's not going to work. It needs to be healthful, right? So I'm not saying all these patients should be on the pizza diet, but they do need to adhere to a healthful diet, and that's more important than having one specific diet that's going to fix it all. Another interesting study is a crossover design, 24 women provided with meals and snacks for 2 consecutive weeks for 4 weeks. And all foods were consumed ad libitum, so they could have as much as they want across 4 sessions. All right. And they were served, 2 daily meals. The difference was foods were different portion sizes and a little bit different energy density, meaning that there's some things that were a little bit more caloric. The interesting part of all of this was that patients that had smaller portion sizes, so they had less that they put on their plate each time, all right, and had less energy density, so had less kind of caloric foods on each plate, or less energy dense foods on each plate, lost weight. All right. And this probably, if you think about satiety like a bucket, right, and you have to fill it with water, if you need to put a little bit, if you're using a cup versus an eyedropper to fill it to the very top, you can probably more easily fill it to the very top of that bucket with an eyedropper, or make it more precise. When they looked at actually looking both portion size and energy density, the interesting part was when you did both of those things, right? If you had a lower energy density and smaller portions, those patients actually had the lowest energy intake. So that you can use those two tactics together. So again, the goal wasn't, these patients weren't hungry, but they were told to eat as much as they would like, all right? But they would have basically a lower energy density on each plate, and have to go up more, right? And so again, so that allows for that more precise response to satiety. It's an easy intervention that you can make with a patient, right? It's not saying that you should be hungry, but you can help them titrate that satiety through that. All right, super. There's no change in hunger scores reported. There may be a hormonal difference in these patients. That wasn't checked, but we don't know. But this might be a tactic. Here's another interesting study. This was looking at patients across the NHS and HPFS, and seeing in these 3 cohorts what foods were associated with long-term weight gain. And unsurprisingly, vegetables, whole grains, fruits, yogurts were associated with lower weights. Okay. Whole over skim milk, probably due to a satiety mechanism. Fats make you feel a little bit more full. Diet soda actually was okay. All right. But you'll see that things like sugar-sweet beverages, fruit juices, processed meats, processed foods in general, butter, sweets and desserts, all these things were associated with weight gain. None of this is a surprise, right? And but there's, this is kind of just data to suggest that this is what's going on. Food quality matters. This was another interesting study that of looking at 20 weight stable patients. They had they could had about 5,000 calories over 2 weeks that they could eat, and one week they were on a processed diet, and on the other week they were on an unprocessed diet. So certainly there was weight gain with the ultra processed food group. There's body composition changes in the processed food group, and increase in fat mass. There's no significant change in hunger ratings, although this was subjective, so not clear that it comes with caveats there. There was increased energy intake in the processed food group overall, and that's likely due to eating faster. So they actually timed the study subjects to say how quickly are they eating, right? And it's probably eating past that satiety, right? These foods were processed foods tend to be made to be palatable, and admittedly, they reported there was no reported difference in palatability. However, this may play a role. What about exercise? Exercise matters. However, there's counterregulation. I didn't get into the hormones of all this, but there's plenty of hormone studies on counterregulation with exercise. So patients were kind of caused to they had a aggressive diet in this study. It was a study of overweight men and women. N was 202. They lost down, lost 8 to 9 kilos. All right, and then were put on an exercise regimen of 1,000 kilocalories per week versus 2,500. And although exercise doesn't cause a lot of weight loss, usually 2 to 3% on its own, it's really important for weight maintenance. So you can see that the difference in these populations with exercise, that the individuals that exercise more had less of a slope on the weight regain. Right? These patients are going to be slowly regaining the weight, but exercise makes a big difference. Exercise also affects the other things that we might be treating, but such as cardiovascular disease and insulin sensitivity. So it's really important for reasons other than weight. But when we're talking purely about weight, it has more of an effect on weight maintenance than weight loss. All right. So sleep, the sleep talk. Where was all the sleep talk? We haven't talked enough about sleep yet. We will. We'll catch up. Don't you worry. This was an evaluation of the Wisconsin sleep cohort. It's 718 sleep diaries. Patients actually had a PSG and vein sampling. And the important piece of this is that this was an association, but patients had heavier patients slept less, right? Had less total sleep time, had higher weights, and had higher levels of ghrelin and lower levels of leptin. So they were hungrier. All right. Stress reduction matters too. All right. So individuals. So this was a case control study looking at women after a stressful event. So stress-related obesity was defined as rapid weight gain after a stressful event. That could have been a miscarriage or a death of a family member or smoking cessation. Or they just had non-stress related obesity, which was kind of a slow weight gain that didn't have a stressful event. And they did urinary free cortisols, and the patients with that kind of stress-related weight gain had a little bit of a bump in their urinary free cortisol. Now this isn't Cushing's level, right? But they did have a little bump in their cortisol, so there may be a little bit of a mechanism there. So we know that patients that are under stress can have more weight gain, and mental health is an important piece there. Okay. So let's talk about therapies. Therapies that change the defended fat mass. So our goals, right, are when we think about weight loss, are either decreasing our appetite or absorption, right, decreasing or increasing exercise or thermogenesis. So all the drugs that are out there affect satiety, right? So they effectively decrease appetite. Doing more on thermogenesis. We certainly can. Well, we tried that in the 1930s with DNP, and it killed people. And we tried again in the 1960s with fistfuls of levothyroxine and rainbow pills, and it killed people. So we don't do that anymore. So they're trying to find safe ways to increase thermogenesis, but we're not there yet. So surgery certainly has effects on absorption, but actually has more effects on satiety. So our biggest mechanism is really satiety here. Okay. And that's how we affect the fat mass. The important thing to note too is that obesity pharmacotherapy is efficacious, but it's variable. So this is the scale trial, and I put this up more because it's representative of how any weight loss therapy works, right? So each of these lines here is an individual, right? And you can see that some people really lost a lot of weight on liraglutide on the far left. Some people gained weight though, right? And there's probably different kinds of obesity. And so we have to optimize therapy for our patients and understand that some patients may not respond to these medicines. And then from a weight loss standpoint, our goal is of at least a 5% weight loss every 3 months. If accomplished, you continue therapy and increase as needed. Even small changes matter. All right. So for us, from a sleep standpoint, it's 7 to 11% has an important effect on obstructive sleep apnea. I generally think of it as 10% or more weight loss has an important effect on sleep apnea. Right. But obviously, you have all these other off-target effects. Diabetes, lipids, hypertension, liver disease, the list goes on. So you have a lot of comorbidities to weight that you're going to be treating along the way. This is more, I'm not going to go through the details of this slide. The big point that I want to make here is that there's a lot of other medicines that might make you gain weight. All right, and thinking about about patients' medicines, what might be causing weight gain is an important piece of this, because sometimes switching antipsychotics is all I have to do for patients. Okay. All right, now let's get into the interesting stuff. Well, probably what we're here to talk about more. Tirzepatide has an average weight loss of about 22%. We usually start that medicine at not usually, you always start it at a low dose, 2.5 milligrams weekly, and you increase it as tolerated. You might titrate it to patients, both to a patient's tolerance and their starting weight. Mechanism of the medicine is it has some effect in the nucleus accumbens, but the primary effect is really the POMC-CARP pathway, which I mentioned earlier is the satiety pathway. All right, and research is ongoing on how many of these mechanisms work. Side effects. These are not benign medicines and they're lifelong. All right, so the important things that we need to think about is gastroparesis. Well, it's decreased gastric emptying, so we have to be careful in patients with gastroparesis or issues of GI motility, gallbladder disease. Certainly, weight loss has an effect on increasing gallstones, but these medicines also decrease gallbladder motility. A family history of medullary thyroid cancer, which is really more pertinent than the MEN2. But the medullary thyroid cancer, which is part of the MEN2 syndrome, is the concern that's in old studies in rats, not with these medicines. It's like with liraglutide. Pancreatitis has been kind of kicked out in meta-analyses, but there probably are subpopulations that really do have recurrent pancreatitis with these medicines. So one of our fellows in endocrine has recently published on this, looking at looked at a case series of patients that had certain abnormalities. So, for instance, cystic fibrosis carrier had a recurrence, and an HFE carrier. So there probably are subpopulations that really do have that pancreatitis. I've put heart failure of less than 40%. This is based on a meta-analysis of the FIGHT and EXCEL trial. So in that trial, which was liraglutide and exenatide, so not these novel agents, those patients had increased heart failure hospitalization on the drug. So you should be careful about starting that and certainly talk to cards. These medicines are contraindicated in pregnancy and breastfeeding. We won't get into the details of that. Nausea. So what's more common is GI side effects: nausea, vomiting, diarrhea, constipation, reflux. There's a mental health caution in meta-analysis that hasn't been shown to be patients tend to have a higher quality of life. In a meta-analysis, I'll tell you that I've had a patient or two say they don't feel good on these medicines, so trust your patient, back off. This might not be the right therapy for them. NAION, so it's an eye disease, non-arteritic anterior ischemic optic neuropathy. Hasn't been shown in randomized control trials, but has been in kind of large retrospective cohorts. There may be some signal. I haven't seen any cases of it, but I still warn my patients about it, and we say, if you have vision changes, stop the medicine and see an eye doctor. Dehydration can happen as well. Patients forget to drink, so they should be drinking about 2 liters of water a day. Okay. Mentioned my interest in SGLT2s. There's also some emerging data on SGLT2 inhibitors. This was some work we did looking at outcome trials in Virtus, CV, and the EMPA-REG. There's a 50% reduction of investigator-reported adverse outcomes in patients that were on ertugliflozin and empagliflozin. This is obviously emerging, but we're doing some kind of prospective work, so stay tuned on that. Metabolic surgery. Metabolic surgery is a real therapy as well. The indications are class 3 obesity, so BMI of 40 or greater, or BMI of 35 with one weight-related comorbidity and you bet that sleep apnea is one of those. So patients with a BMI of 35 with sleep apnea are candidates for metabolic surgery. The important pieces about metabolic surgery is that it is truly metabolic. It has effects on ghrelin and GLP-1, right? So these surgeries actually do increase satiety. It's not just malabsorptive, right? But they do have malabsorption. We're going to go quickly through that, and then we're going to get into some of the sleep data. So sleeve, on average, patients lose 25 to 30%. I'd say 20 to 30%. Obviously, there's surgical complications with these. You're careful with portal hypertension and cirrhotics with these because they can bleed. But there's a lot of vitamin deficiencies. What's more common is calcium, D, B1 through 12, and iron. In patients that can't tolerate a sleeve, nowadays you can actually do an endoscopic sleeve gastroplasty. So it's a way to suture the stomach volume to mimic a sleeve, all right, but through a scope. So really interesting stuff for high risk patients, and effects tend to be there's a little bit less weight loss, but also less vitamin deficiencies with that. Roux-en-Y is the same idea. So every time you cut the fundus of the stomach, you have significant changes in hormones and those satiety hormones, and I won't get into the details of that. With each progression, right, from sleeve to Roux-en-Y to biliary pancreatic diversion, you basically get more malabsorption. So the side effect profiles are similar, right? But you get more deficiencies, and you might be at increased risk of complications. All right, but a Roux-en-Y you'll get 30 to 40% weight loss on average, and then a BPD is the most aggressive of these. So it's an even further kind of skip of the GI tract. and you'll get more of a malabsorption, right? So this is only let's say less than 1% of surgeries. So 80% of surgeries are a sleeve, 20% are a Roux-en-Y, and then about less than 1% are a BPD. So what about the airway, right? We've been talking a lot about weight loss. What about the upper airway? So this is a case that I've seen, all right? Gentleman that I actually saw in the hospital. His peak weight was 443 pounds. He was on steroids, had compensated cirrhosis, gout, tenosynovitis, secondary adrenal insufficiency. All right. So I saw him in the hospital. We found that he had adrenal insufficiency that was secondary. My colleague and I, we started tapering steroids on him. We started him on tirzepatide along the way. He was not willing to do a PSG. His CO2 was high, 33. But his HST showed an REI of 33. His nadir was 72%. Mean oxygen was 87%. T90 was 86%. So he's low a lot of the time. But he's not willing to do a titration. And every time I talk to him about PAP, he's like, no, thanks. I'm not doing that. So along the way, we treat him. I switch him to semaglutide due to supply issues. Switched him back to tirzepatide. And he's down to 234 pounds. So he's lost 46% of his body weight. His BMI is 30. CO2 is still high, though. But he's sleeping better. I don't know if it's fixed, right? That's the problem. So although he's had a massive weight loss, this is the important piece here is that apnea not all apnea is going to be treated with these medicines, and his CO2 is still high, so he still may have a CO2 issue at night. So it's an important piece that these are adjunct medicine. I think I've convinced him to do a polysomnogram, although I haven't seen that come across my desk yet. So we'll see where he's at, and in this slide will be updated when I have more data. Weight loss has always been known to have has been known to have a significant impact on sleep apnea for some time, right? This was an evaluation of multiple studies looking at the reduction in AHI and different therapies. So you'll note that this was before weight loss drugs were on the market. The triangles were nutritional studies, and then the circles are bariatric surgery studies. From this evaluation, they estimated about 1 point of BMI decrease estimated a 6.2% reduction in AHI. Now, and this was in population. And I wouldn't hang my hat on that because there's different components to sleep apnea, right? It's not, and each patient is different. So you really do need to reevaluate that. And the different parts that we always think about is, looking at upper airway anatomy, collapsibility, looking at the dilator muscle activity, ventilatory control stability, loop gain, and arousal threshold. And just a note for that initially it's usually thought that when patients start PAP, they might have a small 1 to 2 pound weight gain, right? So it's something to keep in mind. And when we think about obesity hypoventilation, the components that we think about, and this is a sleep audience, so knows this all quite well, is that you have impaired respiratory mechanics, and increased work of breathing, and there may be a leptin mechanism that's that we have. I hate to say leptin resistance, but I'd say impaired kind of dysfunctional leptin signaling, which causes the hypoventilation and the hypercapnia. So what about endotypes? And so this was a study looking at endotypic traits from polysomnography in patients between 54 and 93. Our own Dr. Zinchuk is part of this study. Um, the interesting parts about this were patients with obesity were characterized by increased collapsibility of the upper airway and loop gain. Right, patients also had high arousal threshold and airway responsiveness. Right, age also was related to increased collapsibility and loop gain. Male sex was associated with increased collapsibility and decreased compensation. And then Black race was in fact associated with lower AHI, reduced collapsibility, and increased loop gain. And then Chinese ancestry was associated with increased collapsibility. So when we think about endotypes of obesity, this was another study looking at polysomnographic studies of 1,364 patients with OSA and transcutaneous CO2. Among patients that were, I think 420 of these were actually had obesity. This was actually looking at patients with hypoventilation, right? And these patients had increased collapsibility, had an increased arousal threshold, had increased compensation. But note that as BMI went up, there was a ceiling effect, right? So there's only so much that that they could compensate. Had increased loop gain, had increased hypoxic burden, and overall an increased ventilatory burden. And these effects seem to be more pronounced in patients with hypoventilation, right? So when you compared non-obese versus obese versus hypoventilating patients, it actually seemed to exacerbate these effects. So this is some work of Dr. Noakes. This was this SLIM OSA cohort. It's looking at 55 cases that were before bariatric surgery, right? Looking at their kind of baseline features. And what they found was, obesity was again characterized by increased collapsibility, a higher arousal threshold. And there was actually the follow-up to this was post-bariatric. After surgery, patients had an improvement in the chemoreflex delay and collapsibility. This was kind of a poster abstract, but after a weight loss, BMI drop from 42 to 34, there were significant improvements in those features. More work there is a difference. This was looking at a different cohort. This was the snooze cohort. There are significant differences in men and women. So men have this was sorry, looking at 2,146 patients. 43% were women. And the important piece was that men and premenopausal women had their apnea was primarily due to collapsibility, but postmenopausal women had this interesting finding of a lower circulation delay due to body composition changes, and that they may suggesting that they have more frequent and less severe events, and that may be due to kind of loop gain effects. All right. So now let's talk about drugs and these and the upper airway. So the scale sleep apnea was actually scale sleep apnea trial was actually the first trial looking at medicine, liraglutide, and OSA. And in fact, there was an improvement, right? There's about a 0.7% reduction in weight, so not nearly as impressive as tirzepatide. And the AHI on average dropped, from 44, from actually, sorry, in the 50s down to 36, but the placebo group was only 44. So there was a significant difference, but not as impressive because the weight loss wasn't as high. But this was the first trial that looked at drugs and weight loss and sleep apnea. Surmount OSA, on the other hand, was obviously the trial that's on everyone's mind. So it's divided into two groups. Trial 1 In trial two, the first group was patients that were non-adherent, and the second group were patients that were adherent with PAP. Right, so they kind of split the study, but the bottom line was that patients lost about 20% of their body weight, right, which is in line with what other trials have shown, and they had about a 50% reduction, sometimes a little more, right, in their apnea severity index. Now, the mean, the baseline AHI was about 51 events an hour. So a 50% reduction still may mean that these patients have at least moderate apnea, right? So again, these medicines are adjuncts, and in many patients, they may not solve the problem. The interesting pieces in this was this really significant change in apnea-hypopnea index, 50 to 60%. In this study, this was a healthy population, right? So they defined patients that might be able to get off PAP as having an AHI of less than 5 or an AHI of 5 to 14, so mild apnea with an ESS less than 10, so very legitimate in this healthy population. And you had, in that, looking at it that way, they had a 40 to 50% reduction. May not be reflective of the real world. And then, change in the hypoxic burden, which is one of the better predictors of outcomes with apnea, there was a significant decrease. So these were all really important findings in this study, and so that's why we considered using these agents in patients with moderate to severe apnea. Now, do these patients have to be on medicine forever? Unfortunately, yes. This is the Surmount OSA. I'm sorry, this is the Surmount extension trial. So looking at what happens when patients stop medicine, and you can see that at week 36, patients stopped. Basically, half the patients were converted to placebo, and within less than a year, regained more than half the weight. So I'll tell you that clinically, within a year to 2 years, patients regain all the weight, sometimes even faster. Right? These are chronic medicines. That's what patients should expect. They will be on these medicines forever. It's not to say that they shouldn't be doing all the other things that make them healthy, but they should expect that these are chronic, lifelong medicines because obesity is a chronic disease. All right, looking at weight loss in OHS, there isn't enough data on this. So there is some nutritional data, and I'm sorry for the small type, but the nutritional studies that are out there suggested that weight loss will help with OHS. The best data is actually in the surgical literature. There are several studies that are mostly observational, but the best data is really was shown with biliary pancreatic diversion, suggesting real improvements in CO2. Right, so there needs to be more data on OHS and weight loss. So conclusions that obesity is complicated, multifactorial, and prevalent. Treatment is focused on adjusting the defended fat mass. This is a team-based approach. I work with a lot of different colleagues, and treatment of obesity has significant and important effects on sleep apnea therapy. However, I'm sorry, on sleep apnea severity. However, it's an adjunct therapy for all the reasons I mentioned. And now I'm open for questions. Thanks. So I'll look at the.
Thank you. Thank you so much, Brian.
Yeah.
That was an excellent in-depth, dive into this novel therapies and obesity, especially for sleep physicians like us. I just had a quick question about tirzepatide, which is the most hyped up thing and most evidence for sleep physician. So is there any evidence that tirzepatide may improve sleep parameters, including, sleep apnea severity independent of weight loss? And also if tirzepatide improves oxygenation, hypoventilation, or daytime sleepiness in sleep apnea patients.
So, I believe it does improve ESS. I think we need more data on OHS. We have data. The best data again is in the bariatric surgery population for the hypoventilation. Um, so we can only kind of extrapolate. There is ongoing research to look at other mechanisms that GLP um, might improve the airway beyond weight loss, but I think that the primary mechanism is probably weight loss.
Thank you. And I do have a few questions here in the chat room by Dr. Yagi. Out of curiosity, was a drug that increased thermogenesis in the 1950s dinitrophenol, which uncoupled the electron transport chain from ATP production?
Yes, that's DNP, and it's 19. I think they used it in the 1930s. So yes, it causes. You'll be surprised. You may not be too surprised to hear, but they're looking at DNP again in mice to see if they can do it safely. So, but yes, that is the drug.
He also has another question. Also, can you speak to muscle loss with GLP-1s and what do you counsel regarding this?
So sure. I didn't have these slides in this deck, but there is a study of liraglutide looking at muscle and bone, and there's reasonable preservation of muscle with exercise, and there seemed to be some more bone loss with despite exercise. So weight-bearing exercise is key to help prevent muscle and bone loss. So not only is it, is exercise really important to prevent to treat other kind of outcomes related to obesity, but it'll help with the muscle and bone loss that's associated with weight loss. Now, the mechanism is not unique to GLP, it's just a weight loss mechanism. There's other studies. So that was Lira. Lira is less effective than tirzepatide, and I think there are other studies looking at that these more aggressive agents really do have more substantial weight loss. There's arguments to say that perhaps the biomechanics don't matter so much, but I'm still of the mind that muscle loss matters and that all these patients should be exercising regularly. There are and so I recommend so the baseline, the goal should be 150 minutes per week, right? That's I say split it between weight bearing and cardio, but in truth, if you want to preserve muscle, you do more weight bearing, and then to really induce more weight loss, you get to 300 minutes, but I don't think it's a realistic goal for most patients. Interestingly, there are some novel agents looking at myostatin. Um, so myostatin and activin inhibitors. Uh, myostatin and activin inhibitors to maintain muscle loss. I don't know if that's a good idea or not. But I think that we need a little bit more research on additional drugs in these patients, especially since they're infusions.
Thank you. There is another question by Dr. Ian Weir. So currently, you stop drug, you gain weight back, but then some new real world data is suggesting that this may not always be the case. Is there any current studies that show an organized approach to keep the weight off with either a reduced dose or off medication?
Yeah, so I don't know what data that is. The only studies that I've seen that have really shown that that's effective is actually I haven't seen too many studies that actually shown that that's particularly effective. The best data that I've seen was actually an NHS study that was really interesting. Patients were switched from GLP to another agent like a Contrave or a Qsymia and managed to maintain weight loss. And these were super responders. So patients that lost 25% or more, actually 20 to 25% on semaglutide. but I don't think that there's any, so far I haven't seen convincing data to suggest that stopping medicine is a good idea. I think reducing medicine, especially with patients who are losing weight too quickly, and we didn't really talk about targets um, in this talk, but when patients are losing weight too quickly, you might reduce the dose, and I have patients on low doses of medicine to maintain weight loss. So it's not unreasonable to decrease doses if patients are losing too much. But usually the goal is to keep patients at a dose that will maintain a plateau.
Thank you. That's very helpful. There's another question by Dr. Stuart Mann. What is the study show with two contrasting strategies, frequent health snacking to increase satiety
Yeah,
versus,
hello?
can you hear me?
I can hear you now.
Oh, sorry. There's another question. What's the studies that show with two contrasting strategies, basically frequent health snacking to increase satiety versus 12 to 14-hour fasting daily strategy?
Um, so I guess I don't understand the question.
I think he's just trying to ask, correct me if I'm wrong, but basically there's two strategies. Are you trying to ask what's the which one is better, whether it's frequent healthy snacking versus fasting? Feel free to unmute yourself. I think that's how I understood the question.
Okay, if that's the question. So I would say probably frequent healthy snacking to maintain satiety. When we're going into the neurophys of how all this works, is that when we get very hungry and we fast for a long time, we start relying on our, as opposed to the POMC cart pathway, we start relying more on the uh, hedonistic pathway, which is more dopamine driven. So when patients fast for a long time, their hunger kind of they get hungrier, right? And they have a tendency to overshoot and actually um, eat more calorie dense foods, right? So they'll have a tendency that pizza is extra delicious and they'll get more of a dopamine hit. So between the two strategies of eating regularly, I would say having regular, um, I wouldn't say healthy snacks, but having more regular meals earlier in the day. There is a circadian effect, so eating late is metabolized a little bit differently. Um, but having earlier meals and having more meals kind of in the breakfast, lunch, I'm sorry, more of your calories earlier in the day, that does seem to have more a better effect on satiety.
Thank you. Does that answer your question? I think that's okay. I don't see any other questions. If anyone has any more question for Dr. Wojcik, please feel free to unmute yourself. We're almost at the end of the talk. One last question, Brian. Just for general, for sleep physician, if we were to start GLP-1 like
Mhm,
tirzepatide, what are the basic things that, we should make sure there is in terms of labs, the patient, obviously insurance? Um,
mhm.
what are the things that you would recommend that we do?
So the big things are that I would say are that for obviously make sure that they're an adequate candidate, right? A lot of patients are ruled out early on because they might not be candidates with that list of contraindications. Um, the tips and tricks is if someone is not tolerating a medicine, it's always okay to go down on the dose, right? So if someone's not tolerating, if they're at 7.5 of tirzepatide, and you need to reduce the dose, that's okay. You can reduce it down to 5 milligrams and see how they do. You don't need to necessarily stop it. Okay, you can just reduce the dose and see how they do. And a lot of people tolerate that just fine. Um, you know, having extra support, and if you're not sure about something, so if you're worried about, again, I say this is a team sport, but if you're not sure if this GI thing is an issue, ask the GI doc. Is there a concern, right? So I'd say make sure to ask people if and make sure that other teams are on board. And I'd say make sure that the patient knows that this is a lifelong therapy, because a lot of people think this is going to be for 6 months and they're going to be done. And unfortunately, that just hasn't come out to be true in studies. I wish it were, but it doesn't shake out that way. Maybe you're able to reduce the dose, but often you're not. Often you have to stay on some sort of maintenance, on a higher maintenance dose to do it, and it's effective, and other problems get fixed. I didn't mention this, but that patient that I opened with, we didn't fix his apnea probably, but there are other benefits to these things too. He actually no longer needed a liver transplant after we got done with him. So always look out for those other off target effects that you're going to be helping. But the primary cares will probably be looking at a lot of that too.
Great. Well, I don't see any more questions. So thank you so much for this excellent
Mhm.
and very engaging talk. And thank you everyone for joining in, and we will see you next week. Thank you. Bye.
All right. Thanks. Bye.